Hi everyone, welcome to researchmd.com. We got a great presentation. Today our topic is Lambert-Eaton syndrome. My name is Pramil, Cheriyath. I'm a program director in internal medicine residency, transitional residency. I teach medical students and medical residents. I'm also director of research and assistant professor at two major medical universities. So let's look at our definition of what is Lambert-Eaton myasthenic syndrome. It's a condition in which immune system attack where the neuromuscular junction. Okay, remember there is an immune system attacking the neuromuscular junction. So that's where the nerves and the muscle connect. It interferes the ability of the nerve cells to send signal to the muscle cells so the muscle can work, right? Let's look at the epidemiology. Estimated worldwide prevalence, 2.8 per million. There are approximately 400 known cases of Lambert-Eaton syndrome in the United States. It can occur any age, and the typical onset is around 35 years age. So if you look at, there are two different classes of Lambert-Eaton syndrome. One is the Lambert-Eaton myasthenic syndrome as associated with the small lung cancer. Other one is not associated with the small lung cancer. Okay, 60% of the patients have associated with the small lung cancer. It's a very strong association with this Lambert-Eaton and the lung cancer. And the people with the lung cancer and the Lambert-Eaton syndrome, they are usually older, and they're predominantly whites. They always have a history of smoking. And in patient there is no associated cancer, that can occur in any stage, and gender preference is neutral in that group. Okay, again, remember the association with the Lambert-Eaton syndrome and small lung cancer, very, very strong. 60% people have small cell cancer, not very good. Okay, so if you look at the pathophysiology, you have to go with the neuromuscular junction that, we have this nice picture on the right side. You got the calcium plays a very important role in it, okay? Because it helps in the release of acetylcholine from the vesicles within the presynaptic membrane of the neuromuscular junction. So if you look at our diagram right here, you got antibodies against the voltage-gated calcium channels. Again, voltage-gated calcium channels that mediate the release of acetylcholine. Okay, so what happened? This blocks the normal flow of calcium, thereby preventing the release of acetylcholine from the vesicles. And there is no or little acetylcholine entering the synaptic cleft. Therefore, there will be minimal or no muscle contraction. So we need acetylcholine. It's blocked. So antibodies against the voltage-gated calcium channel. Okay. Now, signs and symptoms, weakness and fatigue, especially in the muscles. You can say proximal muscle weakness in the leg and arms are very common. The disease may affect the patient to perform strenuous exercises and activities like climbing the stairs or walking in the steep walkway is a problem. Onset is usually gradual. There's often progression of symptoms by shoulder muscles, then can progress from lower extremity to the shoulder muscles, and there's hand and there's a bulbar involvement, speech and swallowing, like dysarthria is going to be there. And Lambert-Eaton also, again, so clinical triad, if you want to discuss, you can say proximal muscle weakness, especially in the leg. Autonomic symptoms or bulbar symptoms present. You can have autonomic symptoms like dry mouth, dry eye and constipation, impotent and decreased sweating, and reduced tendon reflexes are there. And it's also another important sign called a Lambert sign. What is that? Where you grip it, they become more powerful when you repeat it. Evaluation of the strength. Okay, that is called a Lambert sign. Weakness is exacerbated by heat and exhaustion. Okay, when the grip becomes more powerful when you do repeated evaluation of the strength, and the weakness is exacerbated by heat and exhaustion. So the diagnosis, how do you diagnose it? You got two antibodies, voltage-gated calcium channel antibody assay, and you got striated muscle antibody reflex titer. Pretty good sensitivity, both tests. Now, next thing is the electrophysiological testing to be able to confirm the diagnosis of Lambert-Eaton. The first one is repetitive nerve stimulation, RNS, is study of the choice. Sensitivity and specificity is extremely high. On nerve conduction studies, the latencies and conduction velocities are normal while the CMAP is reduced. Okay, so what is the main important test is we talked about the repetitive nerve stimulation test. There will be initial decrement in the CMAP, which is similar to myasthenia gravis. However, brief exercise, there will be steady rise in the CMAP, and they'll be seen by up to like 30 seconds. And then, although the single fiber EMG examination is more sensitive, requires exceptional technical prowess. So low compound muscle action potential is going to be the decrement greater than 10% at low frequency, like 1 to 5 hertz, increment greater than 100% after maximum voluntary contraction or at high frequency. And if you look at the bottom, this is the sensitivity and specificity 97% and 99%. So if you had to remember one test, always think the repetitive nerve stimulation test and the Lambert-Eaton syndrome. And then what the next thing you have to do, we know the affiliation with lung cancer. So all of this patient have to be done, imaging studies have to be done. So you have to have a CT chest followed by a PET scan, which is fluorodeoxyglucose PET scan. And then what you do is like you calculate the delta score. The delta score also predict how many of this patient can develop into lung cancer. So you calculate the delta score. What are the things in the delta score? You got age of onset greater than 50 years, smoking at diagnosis, weight loss greater than 5%, bulbar involvement, erectile dysfunction, and Kanofsky performance status lower than 70. Each of this will be given like a 1 score. Okay, and then you tally it. If the score is between 0 and 1, you have a 2% chance of having small cell lung cancer. Let's say if you add the score up like 4, 5, 6, it's like risk go extremely high, like 99%. So if it is 4, 93%. If the score is like 5, it's 96, and if it is 6, you can say pretty much 100% chance they could have like a small lung cancer. So when you do this imaging studies, always calculate the delta score, and then you can tell how often you have to scan them, okay? Because again, we already talked about it's a huge association between Lambert-Eaton and the small cell lung cancer. So you calculate the delta score, and 0 to 1 rescan in 6 months, and rescan every 6 months for like 2 years, okay? And then rescan if normal. Like let's say, I'm just going to go over again. If the score is between 0 and 1, rescan in 6 months, okay? Let's say you calculate delta score, it's 2, rescan every 6 months for 2 years. If the delta score is 3 and above, rescan, and if normal, rescan every 6 months until 2 years from diagnosis, okay? So it's very important to calculate the delta score and think about the imaging study. So treatment of very depending upon the presence of cancer or not. Remember, small cell lung cancer or not. If the cancer is present, treatment first involved treatment directed at the cancer. Always treat the cause of it, okay? And then the other drug is like 3,4-diaminopyridine is the treatment of choice. It binds to the VGCC, causing them to remain open, this calcium channel, and open for a longer duration, and by blocking the presynaptic potassium channel, okay? Now, there is another drug called verdapase, okay? It's a potassium channel blocker that works by increasing the release of acetylcholine. And then guanidine, increase the release of acetylcholine after nerve impulse. Because of the multiple side effects, the usage has been limited. And then, of course, there is like intravenous immunoglobulin, considered a first-line option to treat the refractory. Again, the word is it doesn't work, with the other thing. If it is refractory, there is a role for intravenous immunoglobulin, okay? And then plasma exchange, when the concomitant use with another immunosuppressive disorder, it can be beneficial in some patients. This is not the first choice, okay? Remember that. So thank you so much for watching. We'll be back with another presentation. Please subscribe to our channel. Thank you.